Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
I don't think there's enough doctors. I don't think there's enough support. And I don't think that the payment models currently completely support what primary care needs to do. I think the main thing is access, and it's access to the right people at the right time.
You are hearing my colleague and friend, Dr. James Howard, board-certified emergency physician and Chief Operating Officer of our practice at Healthtopia Clinics. We have built Healthtopia over the past 7 years to deliver primary care, urgent care, and integrative medicine in a way that prioritizes the people we serve and their preferences as well as individual needs. It seems like this would be straightforward, but finding a way to navigate the healthcare system to get our patients what they need requires grit and flexibility. Qualities Dr. Howard has cultivated through his diverse and high-octane career.
My name is James Howard. I'm a trained emergency physician. My residency training was in Southern California by the beach where there's waves, so I got lucky there. And I trained at a level 1 trauma center in Orange County that is the only trauma center in the area. So we did receive a lot of car accidents and then some stabbings and gunshot wounds. The population that's around there is not greatly served by their primary care physicians, or they don't have primary care physicians. We had a lot of complicated medical cases that came through. I could tell stories for days about it, and I think that it really shaped my ability to feel really comfortable when I graduated. I definitely felt really ready. The education I received there was just really top-notch. I was voted one of the chief residents, and so I was in charge of education, which I really liked that role. I loved emergency medicine so much that I moved to Australia and I flew on a helicopter to rescue people in the outback. And that led me to do an EMS and disaster fellowship here in San Diego with one of my mentors, Dr. Jim Dunford. Through the lens of Dr. Dunford, I learned how to really care for people with vulnerability. With the EMS system, the biggest issue was frequent 911 callers, and Dr. Dunford helped us to look at the vulnerable population and try and get them the services that they needed. And so when I was doing that, I became a consultant for healthcare transformation for a nonprofit research organization. And that helped me to learn more about the healthcare system and the high cost areas, and then ways that we could potentially help to get people the care that they need in a meaningful manner without overspending. I actually am now a primary care physician, and I think I'm old enough to do that now. I think I grew up from my emergency background. I was an ER doctor for 10 years and have been doing primary care for 4.5.
Although Dr. Howard has settled into his role as a primary care physician in Southern California, his career has taken twists and turns, rendering him a wealth of experience managing the most difficult and time-sensitive medical cases, not just in the hospital, but also on the road, in the air, or even on the side of a mountain in Australia.
I was rotating at Long Beach Memorial, and this guy had come back from there doing the same job, and he said, "James, you have to take this job." And I said, "Okay, well, just send me a contact." And this recruiter called me, and they hired me right then and there. And I had to get medical licensing and all that done. My job was actually in Queensland. There's 11 bases there. It's an EMS-based job, and They have really great telehealth there, by the way, because there's really large distances between the hospitals there. So there's these remote clinics that the registrars, also known as residents there, they basically get to connect with the EMS system and manage all of the emergencies. And then we would fly out in a helicopter or by fixed wing in usually a King airplane, and then we would take people back to the hospitals where they need to go. I was trained in underwater escape of a helicopter. I was also trained to be winched off the side of a helicopter onto the side of the mountain. And I actually did quite a number of cases that way where they basically put me on the wire and I was lowered down to go and find the patient with the paramedic and do what we needed to do. The medical director for that company, he did the first successful in the field thoracotomy by clamshell and saved the patient's life. So that was one of our protocols, was actually cutting into the chest and taking a wire and opening up the rib cage by a clamshell, and then doing cardiac massage inside the chest and removing a clot from the pericardium. I got to go to all 11 bases because once a month you had to travel around, and had some really amazing rescues. One patient had a subclavian vein esophageal fistula that when I would get her blood pressure up above 100, she would pop the clot and then vomited a lot of blood. And we actually got her straight to the hospital. I told the story, they opened the OR and they saved her.
That's amazing. So you are essentially a physician planted with emergency medical services to do complex medical transports.
Yes, so some of it was primary in the field where they would say there's a really bad farm accident or car accident. I think we're going to need a physician, and so we would hop in and go. And then others were either transporting to higher level of care if somebody had like a heart attack and needed to be transported for definitive care like a stent or something like that.
And so then you would go fly out to the small hospital or small healthcare facility wherever the patient was being treated by other doctors and then accompany them en route to the tertiary care center.
Yes.
I think it's also important to note that that's not typical in the United States to have a physician deployed in that manner. Maybe you can speak to that a little bit.
Typically, if somebody's going to be transported by air, they need to be medically stable. And so most companies will not accept a transport unless the patient has normal vital signs and they're stable on either a ventilator or with the medications that they're being administered. So that was not the case. We were transfusing blood on these patients. We were giving them pressors, initiating them so that we could maintain their blood pressure and keeping them sedated and ventilated, things like that.
And your colleague at Long Beach, I guess, thought you would be a good candidate for this job because
he knew my personality.
Which is, for our listeners, fill us in.
I was a big wave surfer, chasing waves all around the world. I've surfed in 46 different countries and also just really love endurance sports. I do triathlon now. That's my sport. And I love also yoga and things that are more gentle too.
So not an adrenaline junkie at all.
If you ask my dad, he would say that I am definitely an adrenaline junkie. So. And now I see it in other people that are related to me that are my youngers too.
You have mini-me's now.
Yes.
Yes. Well, and I think it's a stereotype for emergency physicians. I think all of us that train in emergency medicine, we have a little bit of that spirit in us, or we wouldn't go into that field in the first place, right?
Right. That's why I said I grew up.
So you could handle staying in an office all day?
And I love it, actually. I've finally found what is good for me at this point in my life, too. So, which is great, you know.
Dr. Howard's upbringing and attending medical school in Hawaii gave him context for the emergency medical services job he took in Australia. In the Hawaiian Islands, the medical infrastructure is dispersed, designed to bring care to even the most remote locations, in spite of limited resources. The experiences he had practicing medicine in the Hawaiian Islands shaped his perspective on how to do things differently. It's worth just mentioning the differences in access to care on the Hawaiian Islands compared to mainland. Maybe that's something you could speak to a little bit as well.
Sure, yes. So the island of Oahu is where Honolulu is in the state capital, and the major medical centers with all exist there. There is care on every island, and it's depending on the size of the population, it's different. So depending on the amount of need, there's basically a limited amount of physicians and staff, and also facilities. I actually worked for an emergency medicine group there for a year during COVID, and I worked at a critical access hospital there, a smaller boutique hospital, and then another small hospital with very limited resources. And usually the traffic goes this way. It usually goes from the outer islands to Honolulu. During COVID, there was so many patients that filled up those centers that we actually were doing the opposite. We were sending them out to the outer islands. It was a very, very complex situation.
Can you tell me anything else about your experience during the pandemic in Hawaii?
Well, it started out first that there was nobody coming in, and then everybody started coming in for a while, for things that were like, because they were avoiding seeing physicians, people were having heart attacks and strokes and common infections like urinary tract infections, pneumonia, skin infections that they just weren't getting treated because they were scared to see a provider. And we had a lot of COVID infections also. The Queen's Hospital really took over, and they became like the center for the entire state, and they basically knew where all the beds were and where all the resources were that could be allocated and things like that.
Mm-hmm. Yeah, I was working at a critical access hospital during the pandemic when it started as well, and we had one real ventilator in the entire hospital, and then we had one portable vent that we never used and weren't even sure if it worked, but obviously tested it out leading up to when patients started coming through. And then there was also another portable vent that the EMS system on the mountain owned that was used for transport. So really we only had 3 ventilators in our community. And I left at the end of April 2020, so I didn't get to witness what happened after that. Although Dr. Howard has spent the majority of his physician career at the bedside, he also has carved out time for healthcare delivery research, in particular during his Emergency Medical Services Fellowship with Dr. Dunford, and also during his time as a consultant for West Health, a nonprofit think tank in San Diego whose mission it is to support successful aging and affordable healthcare for all Americans.
One of the things I learned at the think tank is that the ER is really good as like a reset button. Like if you need a lot of things done all at once, that's what can happen in the ER in the hospital. You can get labs, you can get a CT, sometimes an MRI, some, urgent procedures, some IV therapy with antibiotics, fluids, or other cardiac meds, or those types of things. But some things don't need to be done that quickly also. So it's basically triage, right?
Yeah. And one of the things we've spoken about on this podcast before is part of the issue and why the emergency department ends up getting filled up is because even if the person doesn't need something immediately, like in the next 20 minutes, they probably need some type of testing or support or intervention in the next 24 to 72 hours. But there's just not a way to accomplish that in the outpatient environment in most healthcare systems. these days.
Also, there's the uncertainty of, is the test going to get done? Are we going to be able to get it scheduled, and is it going to be run, and is the result going to be returned back in a timely manner?
And that is affected by the schedule at the imaging centers being full. It is affected also by prior authorizations that need to get done so that the imaging can actually get covered by insurance. There's just a lot of factors that are unknowns, whereas in the emergency department, we have the luxury of getting things done immediately, and we don't have to go through the same red tape process for all of that.
Right. A neighbor had a herniated disc in her spine, and she came over to my house, and her reflex was just super hyper reflexive. She called and begged for an MRI on a Sunday, saw a doctor on Monday. He said, go to the ER and we'll get you admitted. So she went to the ER, got admitted, got her surgery, and she still has some numbness in that leg, but it's way better than if she would have waited and went through prior authorization process for all of the MRI, and now their insurance is not paying for the ER portion of her visit.
Because why?
I don't know exactly why, but it's like they're saying that she didn't need to go to the ER, but that she did need the procedure.
But that was the only way to get her the procedure quickly, to get everything mobilized.
Yes, to actually get an urgent discectomy done, yes.
Yeah, it's definitely tricky because a lot of times when we're making decisions or recommendations of where to go to seek care or what to do next, we're not really thinking about necessarily the financial repercussions of that. We're thinking about what's right for the person that needs the care. And then, when things are time sensitive like that, you don't really have the ability to verify if something's going to be covered or not. You're just acting on what the person needs. And then you end up with a big surprise if the bills aren't getting paid.
Right.
Which feels worth it when potentially it saved her leg from being paralyzed or something, right? But,
She was getting there. It was pretty close. I saw the MRI myself. So I'm not a radiologist, but it was clear there was a very big, stenosis. Herniation, stenosis, yeah.
Mm-hmm.
On her spine. So.
Well, that's good that she got the care she needed quickly, and it seems odd that the emergency visit wouldn't be covered. I think the proof is in the fact that she needed the surgery, right?
You would think.
You would think.
You would think. How dare you come to the ER to save your spine and your leg?
I don't know. That's crazy.
Just a little bit, like a couple more millimeters, it could have been, paralysis.
It could have been, paralysis of that limb.
Yeah.
After chasing big waves all over the world, finishing medical school followed by residency in emergency medicine, rappelling off mountains to perform rescues in Australia, returning to the US for EMS fellowship followed by consulting for a healthcare think tank, and then working as an emergency physician, both in Southern California and Hawaii, Dr. Howard took all of these experiences and poured them into his newest and most challenging role, becoming a primary care doctor.
A lot of people have at least 2 or if not 3 careers in their life. I kind of view this as my 3rd career, I guess. I was a student for a really long time, and that was my 1st career, and then emergency medicine was my 2nd career. And then becoming a primary care physician was a choice, actually. I was actually really nervous. I didn't think I could do it, and you told me I could, and I believed you. And I realized that it was just like slow ER medicine, essentially.
Do you feel like there's quite a bit of overlap in the cases you saw as an emergency physician versus the cases that you see now in primary care?
It's pretty much identical.
I think that would come as a surprise to the general public, because I think the general public has this perspective that the things that happen in the emergency department are one way, and that they can only be dealt with in the emergency department, and then the things that happen in the primary care doctor's office are different. But I would say that 80% of what I saw in the emergency department, if I had to put a number on it, was really just primary care that came to the emergency department because they didn't have access in a rapid manner to get care another way. Would you say that was your experience in the environments you work?
Yeah, I'd say that about 80%, because like the admission rate was probably around 10 to 20%.
People ask me how many of your visits at Healthtopia are urgent care and how many of them are primary care. And I'm like, well, we don't really differentiate that. What does that even mean? These are constructs that are created by the healthcare system. These are artificial labels, right? We're just providing care to the best of our ability.
It's like who gets the chance to create their own practice and do it in the way that they want? Most people have to abide by certain protocols. Like, I mean, we do the standard of care, but I feel like that's not enough. I feel like that we need to really be reaching into whatever is the best thing for our patients, whether it's, even little things like taking vitamin D, like there's like an epidemic of vitamin D deficiency out there. And the lab value is 30 is normal. The research says probably somewhere between 60 and 100 is better, you know? But in a standard practice, you may get a vitamin D check and they say, oh, it's normal, you're good, right? But when you get above 60, there's that added benefit of the anti cancer property. And that's your immune system being on high surveillance.
And I feel like there's probably so many other examples we could come up with regarding the nuances of medicine that are overlooked by guidelines, because guidelines are kind of a broad stroke and they're really looking at healthcare from a population standpoint rather than looking at an individual person's needs and looking at all their different risk factors and also the way that their body responds to different treatment protocols. I think that's something that as a society, as healthcare professionals, we really haven't made the shift to precision care. Like precision care, I think is coming, and I think a lot of people are looking at it. But at the national level and in even in school, like the way medicine is being taught is still like a population health perspective, and the nuances of tailoring a treatment plan to someone based on their genetics, based on their body's individual response, based on their social factors, all these different things. That's something that we talk about, but it hasn't really been institutionalized in medical schools or in the way that dollars are spent, right? Because dollars are spent based on a population health approach.
Yeah, even that's how pharmaceuticals are developed too. It's like they're they're developed in a way that it treats maybe 70 to 80% of the population without considering their genetics. There was a study done that Eric Topol published about Plavix and acute MIs and stents and things like that. And there's a CYP gene that's maybe 20 to 30% of the population lack that makes it slightly ineffective for treating repeat heart attacks, essentially. People are going to be on different medications, and then their genetics may not match up with regard to their pharmacokinetics and dynamics, which the kinetics are how fast you metabolize, and dynamics is if you can or cannot metabolize. We have a psychotropic medication test, genetic test that we run, and it tells us both of those things. And so I really like that because that's a sort of self-contained test. And when we're looking at psychiatric medicines, I can tell people, okay, you're on this, but maybe, you pharmacokinetically are a slow metabolizer. We should keep the doses really low because it's going to build up in your bloodstream. Or sometimes if there's a pharmacodynamic issue, we can say, you know what? Maybe we should try something else. Maybe that's why this one isn't working. And I think a lot of times we'll get that test for people who have tried multiple medications. They also will tell me something like, you know what, that stuff doesn't work for me. And then lo and behold, we have that, in front of us and we can help them to tailor their medication in that way. So, yeah, that's why I think that that type of medicine is where we should be headed. There's just too many variables that you can't control for in a large population, and it has to be individualized. Precision medicine has to be individualized. It's the kind of medicine that we're practicing right now. It's one by one. Every single person, you have to see where they're at, and you have to figure out what they need, and you have to get them that in a matter of time that is appropriate for what the issue is.
It makes me think about just some of the interactions that I've witnessed along the way. Like a patient's on a medication and it's not working for them. And I've heard stories of, well, my doctor just told me that, like, I just need to keep taking this, or that there's something wrong with me, that the medicine isn't working, or that it's in my head, or something like that. But there really are differences in how our bodies metabolize these drugs and how it affects the effectiveness of these medications. And it's unfortunate because I think the way medical education is still being conducted, and it's really not taking these things into consideration. We're learning broad concepts. Precision medicine is hard, right? Because everyone can potentially respond differently to a treatment, and it's hard to teach because, like, normally the way to teach things is to follow a protocol, and if A then B, if B then C, but sometimes if A then F, like, we just can't always take what you learn in the textbook and apply it directly to a human being because human beings are different.
As Dr. Howard strives to implement precision medicine and a new model of primary care at Healthtopia, he has always kept the lessons he learned from his mentor, Dr. Jim Dunford, close to his heart.
Dr. Jim Dunford was an emeritus emergency physician at UCSD when I was mentored by him. He was the EMS director for the City of San Diego Rescue Fire, which covers 1.1 million people in the county of San Diego, and they have over 500 firefighter paramedics. He also developed what's called community paramedicine for the country, also known as mobile integrative healthcare. He started one of the more prominent programs here in San Diego. He had a paramedic that was really, really innovative. She, played the violin, was a physics major, and could write source code. So she wrote source code with another firefighter and built an electronic health record that could predict where all of the frequent 911 users would turn up. It also had a cost calculator that knew all of their emergency visits and hospitalizations and could tell how much the spend was. And when they did the resource access program, they essentially calculated the millions of dollars that they were able to save the healthcare system. And he really is a social worker in an ER doctor's body. Honestly, a lot of people would say that about him because he particularly cared about people with vulnerability. And he taught me that not only can we care for people, but we can make a difference by changing the healthcare system. The UCSD Emergency Department got a grant where they developed a health information exchange for the county of San Diego and actually added an EMS hub in there where all of the EMS data could be fed over to hospitals. It connected everyone in the area, but also it added that EMS component. So things like when people collapse in the field and you don't know their medications that they're on, particularly things like blood thinners, that can determine whether a patient needs to go into a trauma center for a potential head CT and a full trauma evaluation. All of those things got turned on here because of him and the group there together. And so the other thing that it taught me was the need for mobile medicine in vulnerable populations. That is why I started our own mobile medicine program, was because there are certain people that can't get into the doctor's office, but they need to be seen. I think he really influenced me in that way to understand why we need to care for the vulnerable population with like a sense of urgency too, because if you don't take care, it's going to create more morbidity and make their quality of life worse. So I really think that was one of the most important things that the social worker in the ER doctor body taught me was compassion for people, especially those that have some sort of disability or vulnerability.
What do you think would need to be done to further his work?
I don't know if you remember Project 25. They got all of the health systems to pay for the 25 most expensive people in the county, and the only thing they did was house them and then give them a case manager, and it basically saved tens of millions of dollars from the healthcare system and improved the quality of these people's lives.
Huh.
And then when they went to scale it, it didn't happen because it requires funding, right? And so the money that was saved to the healthcare systems, they didn't want to pay into something that would decrease their disproportionate share funding or anything like that. They want to keep receiving that for taking care of the lower socioeconomic patients and things like that. So
what I hear you saying is that the healthcare systems in San Diego County would rather bill for repeat ER visits because they can make money off of that rather than save the whole system money by simply providing housing and social worker care for these people.
It's the perverse incentive.
Yeah, it's like how many readmissions can we get away with and still meet our benchmark? Right?
Yes.
That's what it is.
Also, I mean, it's too forward of thinking, and I think that's the thing about people like Dr. Dunford is the business model is not completely worked out, and when they go into these projects, that's not a part of the plan. The plan is always to look at the cost savings. What are the outcomes, like in terms of like health, mortality, morbidity, but it's never like, how do we build a solid business model to support this too?
Well, I think the responsibility to help curate that business model really falls on the payers, but ultimately the government, to be quite honest, because it's the government that has the power to regulate insurance companies and how things get reimbursed. And the government controls CMS, which includes Medicare and Medicaid. And the types of services that get covered are essentially decided by the government because CMS sets the standard for what CPT codes are billable services that will be reimbursed. And then typically insurance companies in the private sector follow suit with whatever Medicare does in terms of establishing new codes for new types of services that are innovative. It would be helpful if the people that are innovating have the business model in mind in the programs that they're designing, but if we just limited our innovation to things that are covered by insurance companies or Medicare or Medicaid, that would be pretty limiting.
Highly.
So we would, essentially stifle innovation if that's the way that we approach things. But it's unfortunate. It's sort of the same conversation we have in translational research. Part of the issue is that it takes such a long time from a discovery in a lab to developing some type of intervention that can be implemented in a human being. And a lot of effort has been made to try to reduce that time frame. And that's how we came up with the field of translational research, which is really about taking basic science discoveries and turning them into something meaningful for human beings. But we are lacking that in healthcare. There's not that ability to quickly iterate and innovate and implement something at scale if it's working, because all of the politics involved in switching up codes and making sure things will actually get paid for. It's like moving a mountain. You just can't do it unless, I don't know, it takes an earthquake to move a mountain, right? If you call 911 in the United States, no matter how critical the emergency is, you could be having a heart attack, you could be bleeding to death, a physician is not going to show up with the ambulance. That just does not happen here that I'm aware of. Unless maybe, when we were on residencies, we did ride-alongs for training purposes, but it's not really the standard. That was just more for us to learn about the EMS system rather than to be a routine part of responding in the field. But you're telling me in Australia, it's not like that. It's different.
In Europe and Australia, there are physicians that are deployed to complex scenes and environments.
Why do you think it's like that in other places, but not here in the United States?
Well, there's no payment model for physicians to be in the field for that.
Yeah, there's no way for them to get paid. You don't know if the patient's at network or not. Even ambulance rides in the United States are not always covered by insurance if you're not
Right.
in network with the ambulance service that happens to cover your area.
Yes. And that came up with the whole community paramedicine issue when we were trying to get mobile integrative healthcare and getting paramedics to be able to care for patients in their homes and trying to keep them out of the hospital. There was no way to have some sort of a medical director that was getting paid for by the insurance plan. This works out in socialized medical systems because it's covered by the government, right? You don't have to worry about if you have a PPO or an HMO to get covered. And so by virtue of us having private and public payers, it negated the ability for us to move forward with innovation and do public health. I was actually the principal investigator on a study that was a statewide California demonstration of how mobile integrative health could happen, looking at people that come into the urgent care setting that didn't need to be hospitalized but needed some follow-up that could have been taken care of by the paramedics. So they got enrolled in this program, and then the services that were needed were brought into the home, and the paramedic was the point person to help guide and be the eyes and the ears of the program, but also had a physician that they could report to, and they were considered physician extenders, and they could bill for the visits.
If you're a public health official and you're trying to design a program that you want to apply across a geographic region where you have a broad mix of different payers, the likelihood of getting them all to collaborate on that innovation is pretty low.
And getting the hospitals to agree to share data was a huge lift in San Diego.
Mm-hmm.
And people did still try and opt out of it too. And I'm even noticing in our health record that people that were supposed to be participating, they're not sharing their data anymore. So they've turned it off in different ways.
What do you think are the reasons why the hospitals don't want to share data?
Well, it's market share, for one. I think it's also not wanting people to have a view into the care that is being given too. And
like one hospital not wanting another hospital to be able to review the charts and understand what care was given at that other hospital.
Exactly. Yeah. And because if there's some sort of medical legal thing that's happening, they don't want people to have access to the records, essentially,
Did that topic come up in discussions about the San Diego Health Information Exchange?
There was a lot of discussion around breaking the glass and when that was even an option for people, and like sensitive issues and how those would be addressed. They positioned it as a repository for information that could be pulled when necessary. Not like you can just go in and search things and do things as needed. It's when you're actively engaged in patient care and you're like trying to find an echo. You can see where the echo is, and then you can pull the echo. And so you can only pull things on an ad hoc basis.
So they were gating the data so that essentially you would have to individually select specific things rather than just downloading somebody's entire chart.
Exactly. Yeah.
Which creates an inherent problem, right? If the patient isn't able to articulate what procedures have been done or what to even look for, then how is that helpful?
Exactly. And I think that, being emergency physicians, like we're always operating with pretty much no history, and you kind of know how to get through what you need to get through so that you can give the appropriate care. But I think it does kind of hinder like a hospital's ability to actually, do their job too, because there's probably still repeat testing and repeat MRIs, repeat echoes, repeat catheterizations, maybe even happening, if they can't get the appropriate records. I struggle with this in the primary care setting. My patients will be discharged from a hospital, and all I get is the patient instructions. And I don't even know what happened. It's like they went in there, they did a bunch of stuff, and then the patient is back, and they're on these new meds. It's somewhat helpful, but I don't know what all the diagnostic testing was done. I don't know what medical decision making was made. I don't know the sequence of events and how it happened. So I think that that's the main thing, is it's discontinuous, and it leads to waste, and it also leads to poor quality of care in the end.
Who owns the data, how the data passes hands, who has access to it, who's allowed to look at it. That's been a defining topic in healthcare in the United States for sure. And, HIPAA also is a big part of that as well, and regulates what's legal and not legal. But another layer underneath of that is all of this infighting over data that's perceived as proprietary, and ultimately data really all belongs to the patient, and the patient should get to choose. I think the average person is pretty frustrated when you go to one doctor's office and they can't see the records from the other doctor's office, and they don't understand why.
This happens to us pretty much every time we get a new mobile patient, and so we actually set up a telehealth visit with them first before we see them in person, to see if we can communicate with everybody that's a part of the team, like their power of attorney, and then the patient, and if there's other family members or caregivers that are involved. And then also, that first visit, I turn on the record sharing and see if I can pull in the recent hospitalization or ER visit, because it has all of the diagnoses in there. It has all of the tests that they've had, recent lab tests, and diagnostic testing. And, a lot of times when people move over to the mobile service, they're moving into a living situation where they need more care. And it's usually following some kind of an acute event that started with a hospitalization, and now they need a little more help. So I'm always hopeful that they have something in there so that I can see it, and I clearly know what their allergies are, what they've been through in life. Have they had a heart attack, stroke, blood clots, cancer, like all those things? Because for people in their 80s to remember when they had breast cancer in their 40s, they may not remember that anymore because it was so long ago. Things like that.
Yeah, that data is so important for you to really see the holistic view of what's going on with that person, and anticipate issues that the person may not think to tell you about or may not remember, like you said.
Yep.
How often would you say, when you onboard a new patient, do you find records that are useful versus how often do you not find records?
I'd say 25-75.
25% of the time you find records that are useful.
Yes, or they come with them.
And then, so basically 25% of the time when you turn on the data sharing, you find records that tell you the story that you need to hear. And the other 75% of the time you don't.
That's right. And so we have our mobile medicine coordinator actively searching out for medical records quite often, which is just a job in itself, honestly, in addition to coordinating all the things that the mobile medicine patients need. And we're not always successful either, or it takes months sometimes. So, But that's why I love it when we actually get the information right away. Then I'm like, okay, I know what the care plan is. I know what the history is. We can just move forward, especially in a primary care situation. In an ER, I feel like you don't totally need to know all of that, because you're just addressing the current issue and patching it and admitting to the hospital and getting them to the next stage that they need to be in. But as the primary care doctor, you really need to be the quarterback of all of the issues that the patient is facing.
What do you think are the greatest ethical challenges faced by doctors today?
I think it's fighting the system, honestly, and trying to do the right thing for the patient, but the system not supporting them to do that. And then having to follow some standard protocols because that's what is defined as a standard of care that may not exactly match up with what the patient needs.
Or holding back on things you think the patient needs because it's not covered by insurance, would you say?
Exactly. Or doing things in a different way that you wouldn't normally do it because there's a procedure that is supposedly defined by the payer that needs to be followed. Like prior authorization, things like getting an MRI tends to be a big issue. You would hope that the doctor is ordering it because that's what the patient needs, but then it doesn't meet the protocol. So then it either gets rejected or goes through a lengthy process of getting eventually to a peer-to-peer or the office staff, reaching out back to the insurance company and trying to get people to navigate to get what they need, basically. I wish patients better understood the insurance approval process and the things that we have to do to get them the things that we want for them. Because I think that there's this impression that we're doing nothing when there's just a process that we have to go through, and sometimes we're waiting on a response. Sometimes we have a response that doesn't make any sense that we're sorting out with the payer, and it's a full-time job that isn't really compensated for, that I also feel like clinics have to just foot the cost for it, unfortunately.
Yeah, the more expensive procedures or medications that tend to kind of continuously come up as glitches in the system where there's gaps or delays in getting things covered and getting patients the care and the medications that they need.
I tell everybody that I'm fighting for them every day, and I think that that's the thing, is you just have to know that you're going to fight and you're going to try and win, and when you get it, you're like, yes. So yeah, like I remember the first time I got Ozempic covered for $30 a month. It was like the biggest win, and I was like, finally, we're gonna do this.
These are the things that we get excited about as primary care docs. We got our patient's prescription covered for only $30 a month. Oh my gosh, what a thing to get fired up about. I mean, it is huge though, because some of these things are life-changing for people, and it feels really good when you can make a difference, but it's also frustrating that we even have to go through this process in the first place.
Yeah. Well, perverse incentives.
If you could change anything in healthcare, what would it be? So what's your mind share on what could we do to make things better?
I think the main thing is access, and it's access to the right people at the right time. I don't think there's enough doctors. I don't think there's enough support, and I don't think that the payment models currently completely support what primary care needs to do. And I wish more people wanted to do primary care, I guess, is the other thing. Because it seems to me that people sometimes don't choose to do primary care. It's like if they didn't match into something, then you can always default to being a family doctor or internist or something like that, which is a totally separate topic. But the highest performers in their classes become neurosurgeons and become these surgical specialties that bill procedures at a high rate, and they make more money and things like that. I wish it wasn't such a dichotomy in terms of the reimbursement. Doctors that are highly trained obviously should get paid more, but also I think just the value of primary care is not completely realized by the healthcare system right now. I'm glad I'm doing this. I'd rather be happy and poor than wealthy and tired and angry. So
And frustrated with the revolving door that you have no impact to influence or fix. I think what you said about access is really important. It's getting the right resources to the person that needs them at the right time. And you did a fellowship in EMS. That type of training speaks to that particular concept. What do you think it's going to take for us as a country to move in that direction of getting people the things they need in a timely manner when they need them?
It's all about the payment structure, essentially. I think that if people are incentivized to become doctors, become PAs, become NPs, not take a pay cut to do primary care, and also just not have things so centralized, honestly. Like, decentralization can provide more access to people, right?
Mm-hmm. Yeah, I mean, it's hard to imagine, but if you imagine a world where anyone could just call up their primary care doctor's office at any time, and the person that answers the phone knows who you are and squeezes you into the schedule that day for something, like, what a wonderful world that would be. And I feel like we could stop so many issues from progressing by seeing them up front and triaging, as you mentioned, but also implementing early interventions.
I mean, we were able to do that. I mean, the other thing is also just like the education of patients of when they need to go, where they need to go too. It's like, I feel like people don't know that, like, this is something that my primary care can handle. You know, people show up at urgent cares with chest pain and fainting. Like, you probably shouldn't be at an urgent care if that's really happening. You know, that could be something really serious, you know. So I always think of the EMS system, the paramedics and firefighters, they're the ambassadors of our public health system. And I can't tell you how many calls that they go on that they don't transport patients. And in San Diego, we have a 2-tier system so that we can respond within 8 minutes, which means that a fire truck and an ambulance are both deployed every time there's a medical call. And most firefighters are not putting out fires. They're going to medical calls for most of their shifts. And so, I mean, you think about that resource alone, it's like it would almost be better to just double or triple the amount of ambulances that are around, but there's not enough funding to go around to do that, to staff in that way. And interestingly, like in San Diego, pretty much almost every firefighter is a paramedic too.
If we could figure out a way to take all of the money that's spent on gating healthcare services by insurance companies, or measuring metrics that may or may not actually lead to better outcomes, and somehow funnel all of that into building up a stronger emergency medical services system and stronger primary care access.
I feel like most paramedics that are really experienced can handle a lot of the medical care, but I never get a note from a paramedic that, hey, you know, Mrs. Smith was seen and she was vomiting and we gave her some fluids. Like, can you see her tomorrow, please? You know, right? That would be a dream too, right? You know,
to connect the dots that way.
Connect all the dots, right? Mm-hmm. Yeah. And I've tried to do this with some of the local EMS agencies, and I think they're looking at me like, well, what's your incentive, right? And I just want to provide care at the right time in the right place, and to be able to say, hey, you know what? Like, if you have somebody and you think they need something, let us know. You guys are there. You see what their living situation is like. You can tell they're not sick enough to go to the ER, but they need medical care. You know, they need help. We don't get those messages, and there's just barriers to access, and then there's knowledge gaps.
Dr. Howard's path wasn't a straight line, and it wasn't meant to be that way. In the end, he found a way to blend his passions and create something new. He continues to innovate in search of better ways to bring people the services they need at the time they need them. And he finally feels he has found his home, both in medicine and in life.
I used to say that I wouldn't do it all the same, but now I say I would do it the same because of the way I got to experience my life. And I can just tell you that I'm really grateful to be in this position to be able to help people in the way that I do. And part of that is because, I kind of was like a health nut throughout my life and have always been wanting to be healthy, and I've coached myself into becoming faster, stronger, and having more endurance. And I feel like had I not gone through all of those different pathways, I wouldn't be where I am with a beautiful family and being able to practice medicine in the way that I do. I've learned so much from the practice that we're currently working at, just knowing about ways to get people healthy and even trying to get people just to do simple things like lose weight, get their blood pressure under control, get their blood glucose under control, and watching the excitement in their eyes when we recheck their labs, their blood pressure, and their weight, and all of that is trending in the right direction. And then getting people to their goals and helping them to establish their goals. And by doing all the different things and working in healthcare transformation, flying in helicopters, doing EMS and disaster planning, working at an integrative clinic and being the COO of the company and guiding the culture and seeing the providers also take on the same ideals and mission and want to go out and help people genuinely and in a more holistic manner than what they might typically receive at other places. If I didn't have the pathway that I had, I wouldn't be where I am now today. So I would do it the same.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare through conversation. If you liked what you heard today, please follow this podcast and share it with your family, friends, and colleagues. By spreading awareness, we can bring about change. You can also connect with me on Instagram at Dr. Joy MD. That's DOCTOR Joy MD.